Yeah. All right, folks. I was just telling these guys, I think I forgot to give this talk last year. And nobody wanted to talk in person today. So I was like, let's see what talks I have that I gave in the past. I was like, why did I not give my throwing athlete talk? That's weird. I normally try and give this, I guess we're transitioning in late winter because we start to get so many throwers in early spring. I've been seeing people already though, like it's so weird to me. We live in Cleveland and yet people throw all year long. This is actually the break period. If anybody has a break period, it's kind of like November, December, although a lot of people still work with throwing coaches. But there's a lot of stuff in this talk that's kind of like CAQ heavy. Got it, thank you, yes. Share around, yes, this, good, got it. I have like all these screens popping up on me, so let's see if it works. Yay, we're moving, okay. So it's a little bit of a longer talk. We'll try and go through relatively quickly, but there's a little bit of focus on anatomy, but it's kind of CAQ specific stuff that comes up too. I have to chug my coffee like Austin. Austin and I bonded this week over the fact that we're both heavy omeprazole users. Caffeine consumers. I can't imagine why those go together. So, yeah, helps you tolerate your addiction. So we'll go through a little bit throwing motion, history, physical. Then we're gonna run through a bunch of like specific shoulder elbow issues. I got some interval throwing talk. A lot of the talk is actually based off of some older articles that were published when I was kind of early in my job. But they really still all hold true. A lot of it's just like common injury stuff. So tons of kids play baseball, okay, millions. And it really has become like a year-round sport. You know, like I grew up in baseball was like spring, summer, and that's what people did. But there's for sure a fall ball season, October, November, September, October, sometimes into November. In Cleveland, most of it wraps up in October. So you'll see September, October kids. November, December tends to be a little bit of a down period for kids. But a lot of pitchers will still work with a coach then. And then a lot of people start throwing in January pretty much weekly. And they work their way towards, make sure this is something I'll be trying to get on the call. They work their way towards stuff, the season, doing pretty consistent practices. You'll see batting cage practices in winter. You'll see indoor baseball on limited size fields here. You'll see kids working with pitching and throwing coaches. But then really by March, kids are starting to push outside more. And then the official season's really kind of more April, May for school. The school season is like that long. It's like barely a season. It's tiny. The kids tend to overlap. A lot of the summer leagues actually start in spring. And if you're on a club team in Ohio, you're not allowed to double up and play the same sport at the same time. So if you're on club soccer, you can't play club soccer in the fall for your OHSAA school and play for your club. But if you play club basketball and soccer for your school, that's fine. So when it comes springtime, a lot of the kids who are just baseball kids are stuck waiting for their school season to end before they can then transition into their club season. You can always work with private coaches outside of school, but you technically shouldn't be working with a private coach who's actually your club coach. So there's rules in place to kind of prevent that from happening. But you may see a kid who's a high school pitcher who also works with like a pitching coach during the season. So it's kind of interesting when you start to figure out all the rules and then you start to see people breaking them. But for the most part, they're fairly well adhered to, because if you get caught, it can cause your team like suspensions and disqualifications from state tournaments. So Main complaints and throwers, obviously, shoulder and elbow pain. Elbow pain, elbow pain, elbow pain. We had this 9 to like 12-year-old age range. We just see a ton of it. And the most common thing you'll hear is they've had it year after year after year. So it's not uncommon to see kids coming back in. They're complaining about their elbow pain. And you're like, well, how did last season go? Oh, my elbow hurt. How was the season before? Well, my elbow hurt then too. Did you do anything about it? No. So it's one of those things like people, they hurt and they do nothing about it. And then at some point something drives them in. So it's really important to ask about prior seasons or prior elbow pain. It's all directly linked to throwing volume. Okay, kind of an obvious statement again, but it for sure is. Increased injury risk. So back when I was training, there's like this huge issue about kids throwing curveballs, and everybody's like, don't throw curveballs, you're ruining everybody's UCLs. You shouldn't be having any breaking balls because it puts you at increased risk for sliders, because kids were essentially just torquing the ball like that in order to get the break on the ball. And so there became like a huge move to tell kids no breaking balls until you're old enough to shave, because then probably your elbow growth plates were closed enough that then you were okay to start torquing the ball. The other big move was that people started figuring out how to get the ball to break by throwing it differently. So instead of kind of torquing around the ball, a lot of kids just started kind of coming straight down the seams and doing a lot more forced ulnar deviation. So a lot of times I'll ask kids specifically about what pitches they're throwing, when they started throwing them, and how they throw them. It's pretty rare to find a kid who's doing this at this point, kind of going around the ball, but it's an important injury risk question. So we see kids throwing obviously at higher velocity, longer distances. They're going to be much more likely to have an injury risk. Kids who are not following pitch count recommendations is an issue. You gotta realize that there's pitch count recommendations set out by different leagues, but schools don't follow them because they're not in a league. And then for anybody who's playing club baseball, a lot of times kids double up and they'll be on a travel team and a club team, or a rec team and a travel team. And guess what? They can follow pitch counts on team A and they can follow pitch counts on team B, but nobody's communicating back and forth between the two teams what the kid's throwing. So it's kind of pointless. So we see a lot of issues with kids not following pitch counts, or they're like, oh yeah, we do pitch counts. Well, when do you cut them off? Well, we don't cut them off. Well, then why are you counting? Like, what are we doing here? Like, the whole point of it is because there's actually data that's been gathered for overhead throwing, where we have shown over time you can decrease injury risk if you follow the pitch counts. But sitting there and counting and watching the line in the sand go past you is not terribly helpful. So USA Baseball really recommends 9-month max participation, which means 3 months off of throwing. And if you think about the down period in November, December, that's only 2 months off of throwing. So a lot of kids don't get this. Biggest thing is mechanics. I usually tell people if they're having elbow issues that they need to make sure at some point they connect with a pitching coach so that they can review good mechanics with them. And then year-round conditioning. Just because they're off in November, December doesn't mean they shouldn't be doing anything. This is probably the best time for them to be doing band work and core work, and really learning to coordinate those mechanics to use that core strength to start generating velocity, because the majority of these kids get into trouble if we don't know how to generate strength from their kinetic chain and use that core strength in order to throw the ball. And so what do? They do a ton of snapping at the elbow. So that really huge snap at the elbow to generate velocity is where most of the problems arise from. And learning to use your body to throw is how people can prevent that. So kids should have more than one pitching outing per day. They really recommend avoiding showcases. This is as you're getting older, where coaches come watch you throw because they're trying to get recruited, and it does nothing but encourage kids to throw harder than they should be throwing. And they recommend not doubling up and doing more than one team per season. So you can look up USA Baseball pitch counts. There's also Little League pitch counts. Different leagues follow different ones. But there's restrictions on how many pitches per game and per week. A lot of times they'll give you, based on your age, the minimum number of days off between outings as opposed to just per game. So it's kind of nice to look at when I see kids getting in trouble with elbow pain or shoulder pain. I'll often print up the pitch count rules for them. And most parents are familiar with them, that they exist. They may just not know how to put them into practice. Really, that days off piece is a big one, making sure kids are getting the necessary number of days off between throwing. Probably the biggest issue besides taking the time off is, so let's say you finish on the mound and you're done throwing. Well, where's this kid go play now? So they're off the mound. Are you sticking them at first base where they're not going to have a lot of throws, or are you sticking them behind the plate where they're catching and now they're throwing just as much as the pitcher is? And that's a huge issue. We see a lot of kids move behind the plate. So you have to kind of talk about what other positions do you play when you're not pitching, and try and get them into more limited throwing positions. So the throwing motion is actually pretty important for CAQ. For some reason, they love talking about pitching motion. So there's 6 different phases of the pitching motion. So you have windup and early cocking, late cocking, and acceleration. These are going to be your highest at-risk positions for injury. So late cocking and acceleration, deceleration and follow through. When we talk to kids, we try and always find out at what phase does it hurt you the most. So late cocking is when you're in that maximum external rotation. Acceleration is when you just start to come forward, and that's when you get the most forces right at the UCL. So I try and get an idea of what phase their pain actually starts in, and if they feel it through their motion or not. Softball kids are totally different, right? Softball is more of an underhand motion, and the phase of throwing creates pain in different places. So this is really baseball specific or overhead throwing specific.
Are you just having them like a lot of kids probably don't know exactly when it's popping?
Yeah, I
usually like go through the motion.
I usually ask them, like, when does it hurt you the worst?
Yeah.
And a lot of times they can describe it. If they can't, I'll just say, like, go ahead, start to throw, and like let me know like when you feel it.
Gotcha.
But most of them can tell you it's like, oh, when I'm all the way back. It's pretty, it's kind of hard for them to differentiate between late cocking and acceleration, but they can usually at least tell you, well, it's not when I'm decelerating or following through, kind of thing. So here's kind of the picture of the forces on the elbow. Oh, here's softball. So this is a case picture. I had to write an article about softball years ago, so I took photo after photo until I could kind of get the windmill. So it also has 6 different phases where you're cocking, you're winding up, you're kind of at max overhead, and then you start to come through. Softball players almost always, when they're throwing, their big issue is actually biceps tendonitis, because as they start to come down and release the ball, it's that kind of eccentric contraction to slow the arm down. So you get just completely different issues with them. It's not as much of an issue with instability, slap tears, stuff like that. So it's just important to know that softball windmill still has its at-risk stuff, but it's almost always that release point as they release the ball, and that biceps tendon gets them. So throwing motion is a delicate balance, right? We're trying to get our maximum external rotation, and what do we know happens when you're in max external rotation? Your humeral head wants to do nothing but fly out the front of the glenoid. So you're trying to strike a balance between laxity within the joint and having that stability to prevent it from popping out. And those rotator cuff muscles obviously are the key to making that happen. You should really be generating your force using your kinetic chain. Your power should be coming from your legs and your core, and learning how to transfer that power from your legs and your core to your actual throwing arm is how you prevent injury. If you're weak proximally, people are going to compensate by trying to whip it at the elbow or snap it hard at the wrist. So for all throwers, I strip them down. You got to look at the shoulder blades, because the biggest thing you'll find is that the majority of these kids have huge winging shoulder blades. Well, if your serratus and rhomboids aren't doing the job to tack your shoulder blades down to your rib cage, get your shoulder blades to glide normally, you're going to have abnormal motion of the glenohumeral joint. You're much more likely to get shoulder pain. So, and likewise, the elbow pain comes because you're not strong enough proximally. So really, anybody with elbow pain, you're not only looking shoulder, but you got to go all the way up through the scapula. So these kids need thrown into a gown, or at least t-shirt off for the boys if they're comfortable. but it's important to really strip them down and get a good look. So, as I mentioned, that scapula really positions the glenoid. If it's not flat against the rib cage and gliding properly, you'll see people get a lot of early fatigue with the rotator cuff musculature, and they'll develop a lot of impingement symptoms. You can get those muscles stronger, the rotator cuff can do its job more efficiently and for longer. So it really helps prevent problems. So when I see pitchers come in, I ask a lot of detailed history questions. Again, this kind of gets at like the art of what we do, right? Like it's hard to kind of read about this stuff, but when did you first start pitching? How many total years have you been pitching? I'll usually ask them like any idea how many games you pitched last year. It's insane the volume of games some kids play around here. Like you'll see kids who play in 80+ baseball games a season. That's like half a Major League Baseball schedule, okay? So talking to them about the number of games they play in, how many they actually pitched in, and then when they weren't pitching, what other positions did they play is really important. Asking about that pitch count, how many pitches per outing do you throw, or where do you get kind of cut off? If you're playing on multiple teams, are you kind of tracking that pitch count between teams? Are you getting rest between outings? Are you moving to that catcher position? Or are you stuck going to outfield or second base, someplace where maybe you're going to have still a decent amount of throwing? And then how much downtime are you getting between seasons? And that's really important for the kids who are playing all year long, who give you that history of, oh yeah, it hurt last year too. Oh yeah, I had pain the year before too. And kids, I really try and get them to take advantage of that downtime between seasons to get their strengthening going, because there's nothing worse than having that kid walk through the door in March or April with a Salter 1 proximal humerus. They're going to lose their whole year in baseball. Okay, it's like a 3-month automatic break. So getting these kids to take advantage of that time off and strengthen up is really important. Asking them about what pitches they do throw, age which they started throwing certain pitches, kind of their ratio of fastballs to break balls. And then their history of injuries or missed outings or having to come out early, and if they're working with a coach. And sometimes I'll even say to the parent, like, is there any issues you've seen with their throwing mechanisms? Because they'll be the first to like throw them under the bus and be like, oh yeah, they throw sidearm, it's terrible, we've been working on it forever, but they aren't releasing over the top or even 3/4. They're like way off to the side. I think that's all about just doing a good, history in terms of the pain. Where is it hurt? When do you get it? If it's been happening like recurrent in multiple seasons, like is it happening around the same time every season? What phase of the throwing motion is it happening in? Is it happening right away when you start throwing, or can you throw for 3 innings before it hurts? How long does it take to go away after baseball ends? And then some really big red flag questions are, if you're getting any change in velocity or accuracy. When people start having changes in their velocity, accuracy, or their endurance, then you have a bigger problem going on usually. I'll ask them about neurovascular changes, that numbness, tingling, any swelling in the extremity, things like that. It's more rare, but sometimes you find those issues. Is the pain bad enough it's starting to interfere with daily life? Can you like reach up overhead and grab like the heavy milk carton out? Can you wash your hair? Are you having a hard time getting dressed? Stuff like that. And then ask about loss of motion, strength, any sense of instability. Do you feel like that shoulder's popping out or feeling unstable in any way? So they're really specific questions for throwers. Not that different from specific questions for swimmers. We're on the brink of starting to get swimmers in. So swimmers, we ask a lot of these same kind of conceptual questions about, like, how long can you swim for before you get your pain? Does it feel unstable? Is there a certain stroke that you can do that is worse or better than others? So trying to get those detailed questions really helps us in terms of navigating what they can do comfortably and safely when we're giving them a treatment plan. So exams, pretty straightforward. You guys should hopefully know this by now, so I'll kind of go through it. I always check their range of motion and internal external rotation with them laying down. On the dominant shoulder, they usually have increased external rotation and then a symmetric loss of internal rotation, but you should still have a total arc of 180. We see a lot of throwers tighten up an internal range of motion. So it's really important to check this, because if they're getting tight on internal range of motion, you gotta stretch them out. The anatomy, so main spots you want to pay attention to, you guys probably know that pretty well already. But thinking about the rotator cuff musculature, this is gonna all get at a question. Looking at the quadrangular space, which is on that bottom right corner. So a very, 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 very common question on CAQ are, what are the four quarters of the quadrangular space? I don't know why they love asking this question, but they do. So I for sure recommend you guys review it, but you're gonna have teres minor on the superior aspect, okay? You end up with humerus on one side, triceps on one, and then coming in the bottom is teres major. So they love asking this question. And it's really annoying because the way they give it to you is, you know, you get four options and there's like one thing off in each one, and then you have to like, so you gotta know all four. It's really annoying. And we'll get to, yeah, and I have it in a later slide, I'm pretty sure. So it'll, yeah, so I'm pretty sure that's what they want you to know, but there's a later slide and it goes through why it's relevant. Personally, like I tell people all the time, I've never diagnosed anybody with quadrangular space syndrome, right? Because what am I saying they have? Probably rotator cuff tendonitis, because their teres bother them. So I'm probably going, oh, you got rotator cuff tendonitis, because how do you treat quadrangular space syndrome? By doing rotator cuff rehab. So I don't ever diagnose anybody with quadrangular space syndrome, but for some reason the CAQs love to ask anatomy questions that are clinically relevant, and this is one they deemed clinically relevant. And then I always think it's funny that, you know, teres major is inferior to teres minor. That's another question I've seen sometimes. That, you know, for some reason I always think major is superior, but that's not the case. And then the other relevant thing that we'll talk about is going to be that suprascapular nerve that's up top there, which we'll kind of get to, okay? So differential diagnosis wise, we're going to kind of go through some extrinsic shoulder joint issues first, and then we'll move more intrinsic from an extrinsic perspective. Obviously, rotator cuff tendon issues, subacromial impingement, little league shoulder, and then scapular dysfunction. You know, we tend to be pretty vague when we see people with winging scapula. We're like, you've got scapular dysfunction. I don't get too crazy again with the semantics. I'm much more of a forest than a leaves on the trees person, but they do break these up. I will differentiate if somebody has snapping scapula. You'll see a superior medial bursa that sits right up here. And some people, if they get that scapulothoracic bursa, you can actually see like a pocket of swelling in that superior medial area. And when they start doing moving, it'll start snapping over that bursa. So sometimes I'll be specific about that, but I don't put on anybody's chart that they have sick scapula syndrome. I just write scapular dysfunction, right? But the majority of people that we see probably do have sick scapula. So you get scapular malposition that it should say inferior, not anterior, inferior medial border prominence, some coracoid pain and malposition, and dyskinesis of scapular movement, okay? Super common. It's scapular dysfunction. So rotator cuff tendonitis, you guys probably see a million times a day with adult folks. I have some right now. It's driving me crazy. I'm trying not to make any of you eject me. You get kind of diffuse pain, some weakness, some decreased velocity, especially from a throwing perspective. That's really common. Treatment is to strengthen, strengthen, strengthen. We rarely do corticosteroid injections. If there's a kid who's done growing and their shoulder pain's really bad, we'll think about it. I've had a couple older swimmers, like girls 16, 17, 18, who I've had to inject to try and get their shoulders to settle down. But you know, boys, I probably wouldn't inject them until they had like closed physes, and you know, like we just don't see that many on the boys' side. Yeah.
Are you typically, like in kids especially, getting an MRI prior to doing that? Or
No, so I mean, kids don't, I've seen like one partial rotator cuff tear. Kids just don't tear their rotator cuffs. So yeah, I mean, if they come in and they have like classic impingement stuff, I'll at least try an injection. Sometimes I'll MRI, I'm looking for labral pathology more than anything. So if I'm concerned about labral pathology, you're not wrong MRIing them up front and then doing an injection. Because sometimes those throwers, can definitely tear their labrum, which we'll talk about. The swimmers, I just almost never MRI a swimmer with shoulder pain because you find nothing. They're all ligamentously lax and they all get rotator cuff tendonitis. And they all come in built like this, which Justin's about to see in
I just
his.
saw one yesterday,
Yeah.
same exact thing.
You have like,
Right.
yeah, you have like the high level men's swimmers, he's got the high level women's swimmers at his school, so you guys are two high level swimming schools. So you'll see these kids and they come in like this, you know, it's like, okay, well, let's stretch your backs and strengthen your back up and talk later. But even these kids who are really ligamentously loose, they're symmetrically loose and you just don't see labral tears. Throwers, you are more likely to see them. But corticosteroid injections in kids, you know, the kids who are growing, we just don't do. And from a kid's perspective, like I said, you're almost never seeing tears in these kids. And people come in all the time, the parents are like, we want an MRI, they tore their rotator cuff. I was like, no kid tears their rotator cuff. It's exceptionally rare. If they do anything, they tear cartilage, we can look for that, but it's not gonna be a tear of the rotator cuff. Proximal humeral epiphysitis, which we call little league shoulders. Anybody seen a case of this yet this year? Yeah, so this is actually pretty common. I've had a couple kids. We had that one kid up in Mentor, or Willoughby, wherever we are now, Brico. I don't know if you saw this kid with me. I had a kid with a massive growth plate widening. I just saw him in follow-up too. So these kids look a ton like an adult with impingement, okay? They're like, it hurts here, it hurts going overhead, but they're at the age where they have an open growth plate and they're throwing and they have like resistant achiness. I've seen more cases recently, I'd say in the last couple of years than I'd seen in a while, and I don't know why. But these kids, it's strictly volume. Like I had a kid come in last year where he was playing travel ball and then like at the end of the summer, the coach said to him, oh, well, if you know, you get stronger with your throws, you could probably make the higher level team next year. So the kid went out and they had like a bounce back in the yard and mom said for like 3 days, he did nothing but throw the baseball as hard as he could at the bounce back. And then he came to see me like 2 weeks later and he's like this little skinny kid and like literally his upper arm was swollen. And I was like, he broke his growth plate. And the mom's like, what do you mean? Like, well, what do you mean? I was like, I can like, let's x-ray. Sure enough, like his humeral physis is like flapping way open. And the kid had done nothing but thrown for 3 days and broke through the physis. So you'll see cases like this where kids just throw and throw. It's usually not acute like that, right? Usually the story is like, they're just getting high level throwing. They're playing a lot of tournaments. They're, you know, they're the bigger kid on the team. They get thrown more often. They weren't conditioned coming into the season. But you have to have an open proximal humeral physis before it can happen. And it's unusual for them to get this fracture if this is still open. So if the elbow is still open, you don't see this as often. But I've had a couple kids who have had it. So it's kind of interesting. They tend to be tendered directly over the head of the humerus. They hurt with resisted motion. They hurt with apprehension because it kind of mimics cocking phase. And then when you x-ray them, comparison views are helpful. So here's like a good case of widening right here. If you're not sure if it's widened or not, getting the other shoulder is not unreasonable. And some of us will just automatically order bilateral shoulders to get an idea. Other times we'll get one and I'll say to the parents up front, like, we're going to start with just x-raying the side that hurts today, but I may send you back and get a view of the other shoulder also. But let's see if it's obvious, because if it's obvious, it's usually obvious. And then if the parents in total dismay about the season being over, or if the diagnosis is still questionable on x-ray, but you really think they have it and you think you need to shut them down, you can absolutely MRI them. Again, I hate insurance companies because you want to MRI somebody for a little league shoulder and they don't care if they'll sign off on it, but you want an MRI for a spondy, which can cause lifelong back issues, and you can't do that for 6 weeks. So it makes no sense, but insurance companies never give you any issue about this. you're like, oh, I think they have a stress fracture in their upper arm, which is never gonna affect them for more than 3 months of their life, but anyplace else. So you can just MRI these kids and you'll see like a disproportionate amount of edema within the physis. It's normal to have some edema in the physis because it's a growing area, but you'll have a disproportionate amount. Sometimes you'll see swelling extending beyond the physis into the upper humerus itself, and kind of in the surrounding area. So that is one way to go. So why do we care so much about it? Well, it takes forever to settle down, right? Like it just takes forever. So these kids, it sucks. Like pretty much the rule of thumb is no throwing for 3 months. So I've had kids bad enough. I've had to put them into a sling to rest them. Most of the time it's just chill, go to physical therapy. Let's get back your range of motion. Try and get back your strength. And then I don't let them throw for a while. They're just down.
Are you allowing them to do any other like sport or activity besides like just rehab?
Such as?
Oh, just if they were playing anything else, because I've just seen this picture, just reminded me that I have seen this, but not in a baseball player. We saw it actually in a football player. Not that I would
Yeah.
return, we didn't return it in football, but I was just curious if there's like other.
So if it was a quarterback, I'd say go play running back.
Yeah, okay.
Yeah. Yeah.
Gotcha.
So, and yeah, so that's a good point. Like, this is not just, an injury in baseball, right? So I've seen it in tennis players, volleyball kids, football quarterbacks, swimmers. Obviously, baseball's the most common, hence the name, little league shoulder.
Following up with Austin's question, say it's the end of the season, they're going into basketball. Do you restrict them when they're in basketball?
So that's a good question. Like I would, if they had some downtime, like I'd probably make them chill for a month and then I'd bring them back. If they had full range of motion and full strength, I'd think about letting them work back to basketball. Basketball is pretty shoulder protective. Like when you're shooting here, it's just not a whole lot of shoulder motion. What gets you in trouble is like blocking and defending out to the side, and that's not going to put a whole lot of stress there. So I'll let them, like, you just have to kind of think about, it's once they're at the point of having pain-free motion, you can probably do that. Yeah, if they're going back to soccer or something, fine, go do it, whatever. And you know, there are a lot of times where we modify what they're doing. We're like, oh, you have shoulder pain. For a kid with more rotator cuff tendonitis, maybe I pull him off the mound and stick him at first or have him DH. This isn't one I usually let him stay on the field for. I oftentimes don't even let them like hit through it, just shut them down. So intrinsic, we worry about a couple different issues. From a bony perspective, you can have a bony Bankart lesion at that glenoid that doesn't really project very well, but there is actually a fracture line there that you can see. OCDs can happen in the shoulder. I have never seen one, okay, not common. Osteoarthritis, and then a Bennett's lesion is you can have mineralization in the posterior inferior glenoid with some capsular traction, and then biceps tendinopathy. From a soft tissue perspective, we're talking labral pathology and a haggle. So we'll talk a little bit about these. So the anatomy of the shoulder, when you start to think about this, you guys have probably all heard me at some point talk about this with families, but I essentially describe the shoulder as a golf ball and golf tee, super shallow tee, big old golf ball sitting on top. The only thing we have that makes the tee deeper is the labrum. I always tell people the labrum's like standing over a golf tee and looking down, and somebody takes like a little rubber washer from the sink, pops it right on top, and that's kind of like your soft tissue edge to kind of deepen the sockets. And then we have two other things that help us keep the ball in the socket, the ligaments that connect bone to bone, and everybody, it's a genetic dice roll for how tight your ligaments are. I tell everybody it's no different than hair color, eye color, skin color. You get what you get. It's a genetic dice roll. It's like picking a random rubber band off the giant rubber band ball in the junk drawer, right? Some people are tight, some are loose, but you're usually symmetric. And then our rotator cuff tendons. So rotator cuff tendons, labrum, and then ligaments are all that you have to keep the ball in the socket. But because the socket's so shallow, we get awesome, crazy shoulder motion, right? But awesome, crazy shoulder motion translates to high risk of instability. When you look at it kind of from looking directly at the glenoid, you can kind of see top surface supraspinatus coming around, then infraspinatus, and then teres minor. And then more anterior, that's where you can really start to see subscap coming in, and then the glenohumeral ligament complex. So slap lesions are most common in throwers, all right? So type 2 in particular, where you get more of a peel back is what you tend to see. And the superior labrum detaches right where that biceps anchors in. So that biceps just pulls on it and ends up tearing it essentially. So we will see this happen with throwers at times. I think it's really hard on exam to diagnose a slap. For me, I go looking for them when I'm just having persistent pain. Certainly if they report instability, that's one thing. A lot of these kids don't, it's just persistent pain. And I probably don't go looking for them as much as I should, honestly. I'm more aggressive probably about like hip MRIing for labral pathology than I am shoulder MRIing for labral pathology. So you can see a nice picture here of what that looks like. That biceps comes in, hits the labrum, and it just kind of peels it right off the surface of the glenoid. So I always like that arthroscopy picture. You can have a bony glenoid fracture, and this is why we x-ray these kids off the bat, because if you see a chunk of bone that's broken, you know they're headed for surgery, and that's not anything you can wait to fix or rehab. So a lot of times bony ones are just not common. They tend to be pretty traumatic. They're not likely going to happen with just throwing. And then obviously fibrous are much more common in that anterior inferior glenoid labral tear is also a common location. You'll see Hill-Sachs deformities and a good chunk of Vanguard lesions also. There's a couple different examples of what it looks like on MRI. These obviously are done with contrast. So these are people who had arthrograms, so all that fluid's in the joint. If somebody has an acute dislocation, that acute dislocation causes swelling in the joint and can act like your arthrogram. So if somebody has an acute dislocation, it's not a bad time just to get their MRI done right away, because they're essentially creating their own arthrogram for you, which is kind of nice. Pagol lesions are not common, so you can have a humeral avulsion of the inferior glenohumeral ligament. Again, it tends to be something that needs surgery to fix, just causes ongoing pain. And then glenohumeral internal rotation deficiency. So this is what I was getting at earlier when I talked about making sure you're checking your full range of motion, because you'll see people have loss of internal range of motion. And in particular, throwers will get really tight. And so you have a higher rate of having a slap lesion if you have this. So we really try and get people to do significant stretching when they have it. And has anybody seen the sleeper stretch before? Yeah, so you just lay them down on the table, when they're laying on the table, you get them to put their arm up, and then you have them start to work on pushing it down, so that I usually tell people just get into bed a couple minutes early every night, start working on getting that internal rotation. But I'm amazed sometimes you'll see these little kids with shoulder pain, and then you'll lay them down and you'll check their motion, and it's like, oh my God, they have like 30 degrees loss of internal rotation. If you can fix their internal rotation loss, their shoulder pain goes away, and all it takes is a stretch. So it's an important one to check, and then an important one to prescribe for people. So other things we think about, neurovascular issues. So there's a couple different neurovascular issues that can happen in the shoulder. Most common is thoracic outlet. We see this a lot in people, super common in swimmers also. So maybe it's not a bad time to get this talk because of all the swimmers you're about to see. Have you guys seen some thoracic outlet cases? It's annoying. I haven't. Does anybody have it? So like I can't like do yoga and go overhead for like more than, I don't know, 30 seconds. Like I'm already going numb and tingly on my left side. Is that you? Yeah. So like I had a kid in yesterday, he's had some recurrent shoulder instability issues. People with shoulder instability, which is why I have rotator cuff on the left side. I definitely am unstable on the left. I have no idea why. But when you are loose, and those rotator cuff muscles are working extra, a lot of times we'll also see some thoracic outlet. So thoracic outlet people will complain mostly about numbness and tingling, sometimes the sensation of heaviness, much more common in swimmers than throwers. But I'll always ask, especially swimmers, are you getting it in one side or are you getting it in both sides? But people get thoracic outlet because of tightness, usually in pecs and or scalenes and traps. So you think, oh, your swimmers coming in, or these big beefy people who look like this, and they're all tight in their pecs. So getting them to work their pecs helps. Mary also does some manipulation that can really help thoracic outlet people. But when you're talking about throwers, I'll usually ask them, like, do you have a sensation of heaviness in your arm? Is there any numbness, tingling? Have you seen any swelling? Because what you're trying to rule out is an effort thrombosis. So some people are at risk for getting bigger, deeper, uglier, concerning problems than just thoracic outlet. And then we'll go through kind of quadrilateral space, long thoracic nerve palsy, suprascapular nerve palsy, and this is kind of a heavy section for CAQ stuff. I don't know why they love asking about this. So kind of that anatomy here, you can see different neurovascular compression sites that can lead to thoracic outlet. An extracervical rib is another one that can lead to it. Not common, but sometimes if I have somebody with persistent thoracic outlet, I'll at least do an AP cervical spine and make sure they don't have an extracervical rib up top at C7. But usually it's scalenes and then that pec minor where they really get a lot of compression, especially when they're in that externally rotated position. Symptoms, you can have fatigue, loss of velocity, that big shoulder pain, heaviness, and then from a nerve dysfunction perspective, you're going to want to look mostly at that brachial plexus, lower trunk of that ulnar nerve, asking about any weakness in grip or loss of dexterity. Super rare, don't see it much. From the arterial perspective, subclavian, you're going to have coldness and pallor. From a venous perspective, swelling and mottling if you have an issue. So axillary artery is the one at risk for thrombosis because as you go into external rotation, you get compression at the lateral end of the first rib, and recurrent compression causes trauma over time, and you can eventually get a clot in that axillary artery. So you can imagine if you clot in your artery, things don't go so well, right? So you get a big sensation of heaviness, you're not getting enough blood flow, you're going to fatigue earlier. And the hardest thing is diagnosing these things because guess what? It's really hard to see on Doppler because it's something deep, right? You're not getting it up here in the arm. With an axillary artery, you may see diminished blood flow on Doppler, but you're not going to see the actual clot. So really, a lot of times you end up having to do angiography and you have to do it positional. So we work with the vascular folks a lot to try and figure out how to image these people appropriately. From the subclavian perspective, the other thing is if somebody comes in with a subclavian clot, like just looking at both arms, you'll see some subtle swelling in one arm. I've seen kids who've had a long-standing subclavian clot and they'll come in and they'll have like a crazy pattern of secondary blood vessels that have developed to try and get the blood flow back. So you'll look at their arms and you'll be like, oh, what's going on there? And you have a swollen arm, crazy blood vessels, and you know you're probably dealing with a clot. And I've seen some kids who've gone like ER, it's Doppler negative, Doppler negative, Doppler negative, because guess what? You're only Doppling to the armpit and all these problems are happening in the chest cavity. So these folks need kind of like MRA, MRV combo scans done pretty emergently. And usually the only way to get that done is through the ER. And it usually takes a direct phone call. So you can say to them, please stop Dopplering this kid. This is an MRA, MRV issue. And then God forbid you find a clot, you're stuck getting adult vascular involved. So it's not much fun. We all have had these kids. They roll in every couple of years, but when you see them, it's something emergent that you want to take care of. And if you have suspicion, you just send them into the ER and you're like, they need MRA, MRV chest. And if anything comes back, you got to call adult vascular.
You're getting it done for the chest, like that's the order.
Yeah, it's usually MRA, MRV chest, and I'll call and I'll talk to whoever's there and just like let them know what I'm looking for. But it's a pain in the ass to order. It's a pain in the ass to get it done, and then it's a pain in the ass when it's positive. And usually, if your suspicion is high enough that you're sending them in, it's almost always there. It's a rare problem, but you see it.
Will this be picked up on like CTA of the chest? Do you see it typically? Or?
Yeah, probably, but we usually MR them.
Yeah.
Here we go. Here's your quadrilateral space. Teres, necky humerus, and then long head triceps. So it's not just triceps, they want long head and the triceps. I knew there was something else. And then the weird part is knowing which is which. Like I said, Terry's minor is superior, Terry's major is inferior, and that's like so counterintuitive to me, right? So,
The question be like inferior border Terry's.
mine was just pick the 4.
Okay,
And it was a bunch of different combinations, so I didn't have to know those, but you know, I also CAQ'd last 9 years ago. And it was on my original and my research. So. Yeah, so it's 1 out of 200 questions. Yeah, I think it's like one of those that's always on. What's that?
We'll get a 0.
Yeah, it's a good one to know. So, like I said, this to me is rotator cuff tendonitis on exam, but they describe intermittent vague pain. It's posterior joint line, right? Distal radiating paresthesias, which, maybe, tender to the touch. And then you essentially you do rotator cuff scapular strengthening, and then you do some internal range of motion stretching and people get better, also known as rotator cuff rehab. Okay. Suprascapular notch. This is another one. They love to show up on CAQ. Okay. So the suprascapular nerve can get compressed in 2 spots. And knowing where it's compressed is apparently clinically relevant to your existence as a sports medicine doctor, also known as I would go Google it if I ever had concern in clinic. So you have compression of the suprascapular notch can cause supraspinatus and infraspinatus weakness because of the transverse scapular ligament compressing it, okay? If you get compressed at the sphenoglenoid notch, it's almost always by ganglion, and that gives you isolated infraspinatus weakness and atrophy. So suprascapular notch has supraspinatus included, sphenoglenoid does not. So I tried to remember it was suprascapular has 2 S's, supraspinatus has 2 S's, so they travel together, versus sphenoglenoid is just 1 S, and so it's only infraspinatus and
It has a G in it.
supraspinatus. Yeah. G due to gangly, exactly. All right, have you seen the guys like ultrasound people looking for this at all?
We talked about it when we went through.
We're looking at sphenoglenoid versus suprascapular notch, yeah. So I don't know how often they actually see a ganglion in that spot, or if they can diagnose it, but anyway, so why do we care about suprascapular nerve compression? Because it's CAQ relevant, but because you can't see atrophy as a result. So another reason to strip people down whenever we're seeing people shoulder pain, strip them down. You got to know what normal looks like. You got to see the other side. You're looking for that atrophy more than anything else. These folks tend to hurt with more follow through. You can do ultrasound for visualization, looking for that ganglion. And then they recommend treatments, just essentially nerve blocker. You can have a ganglion removed. So here's another picture of that infraspinatus. All right, moving on to elbow. We're in the home stretch. I only have 11 more slides. How are y'all doing? Hanging in there? Yep. All right, try to finish up. So little league elbow, OCD, Panners, which I hate. Medial epicondyle avulsion fractures, ulnar neuritis, and UCL sprain. So this is little league elbow. There is a spectrum of what people call little league elbow. To me, little league elbow is just that medial epicondyle apophysitis. I have a growth plate here. I throw too much, my growth plate's open, and now I have pain here. But when you read in the literature, little league elbow can be like a big garbage bag terminology where people throw any medial elbow pain in a thrower's little league elbow. I don't view it that way, but you'll see people talk about loose bodies, avulsion fractures, OCDs, like little league elbow. Just because little league players get that problem, to me, it's not little league elbow. To me, it's specifically medial epicondyle apophysitis. Happens younger than little league shoulder because that growth plate shuts earlier than in the shoulder. Kids, especially boys, grow at different rates, which you probably all know. And so you can have a kid who's 15 who still has an open medial epicondyle, but a lot of times they can be shut before then. Just depends on where kids are in their growth. These kids almost always have just insidious onset of pain, right? I throw, it hurts here. I throw, it hurts here. Have you ever felt a pop? No. Has the elbow ever swelled? No. when they avulse it, it is obvious, okay? I threw once, I felt a pop, my elbow swelled, I couldn't keep throwing, all right? So it's a standard avulsion fracture like you think about in the pelvis or anyplace else. Little league elbow, they're just inflamed. And again, this is where comparison views can be super helpful. I'll often start with just x-rays on one side and say the same thing. Look, yeah, we're gonna x-ray one side. I may have to send you back for a second one. Other people just automatically send people for two. But it's not always clear. The avulsion fractures, usually pretty obvious. They come in, they have pretty limited range of motion, they're swollen, they feel a pop. There has been a move to treat the medial epicondyle avulsion fractures with more aggressive early mobilization. So I almost treat them like a radial neck fracture. I'll usually splint them or cast them for maybe 10-ish, 14-ish days at most. And then I try and get them moving. And there's some literature showing that kids do better with that. The cutoff for needing a screw put in to reattach it is 1 centimeter. So if anybody's close to 1 centimeter, I usually have peds ortho take a look at it in those younger kids, because occasionally they do need reattached, but they tend to be like, oh yeah, they're fine, no issues. But if it's a higher level throwing kid, especially, like I'll have peds ortho take a look at the film. OCDs at the elbow, you can absolutely get these in throwers. So here's a nice picture of one, okay? So much like the OCD of the knee, you're looking for kind of like that pothole looking appearance. These kids come in, they have lateral elbow pain or anterior joint pain, okay? So it's not your medial epicondyle person, they hurt more here or lateral. And this, when you're in external rotation, this is your distraction side, right? So that side's pulling apart, where this is your compression side. That radial head is just jamming that capitellum. So I've seen a kid before with like breakdown of the radial head, only once, rare injury, but more common would be to see an OCD of the elbow. I've seen it by far in way more gymnasts than I have throwers. Okay, those kids who just launch and weight bear on their arms are at high risk for this. Likewise, UCL tears see in gymnasts. I've seen UCL tears as young as 10 in gymnasts, where you're like, oh, they probably popped off their medial epicondyle, and you x-ray their medial epicondyle, it's fine, but they hurt crazy medially, and you MRI them, and it's like a 10-year-old who tears their UCL. So it's just high force on the elbow for those kids who are tumbling. These kids a lot of times present with loss of range of motion with their pain. So anytime you see loss of range of motion, you have to have a higher suspicion that there's something bad going on in that joint. You almost always can spot them on x-ray. It's always a shit diagnosis. It's not anything you want to tell somebody. It's gonna require surgery and take a long time to get better, and they may or may not make it back to where they were. It's a really hard one to get better from. So here's that picture again. AVN might as well be an OCD because they're really hard to tell apart in young kids. So there's a benign problem called Panners, which happens at the same spot where we see OCDs. And it's just an episode of AVN that's benign. The pain tends to be more mild. They tend to reossify over time, but they can present with like this recurrent aching in the elbow. It's in the same spot. They may have a little loss of range of motion. And then you x-ray them and you're like, oh, great. Is this an OCD or is this Panners? I have no idea, because they'll have just like some funky looking thing on the x-ray. And a lot of times it can look exactly like an OCD, but happen in young kids who aren't necessarily doing a whole lot of throwing. So separating them out is really, really hard. I usually start, if there's anything that looks funky on the x-ray, I start by doing an MRI, and I tell the parents up front, like, it's really hard to know if this is gonna be an osteochondral defect and be bad and need surgery, or if it's more loss of blood supply to the area and it's gonna fix itself over time and it's not a big deal. And we're probably stuck just watching and waiting and seeing what happens. So when you see these kids, the Panners kids are younger. So they tend to be 8, 9, 10. So the younger you see them, the more likely you're thinking, okay, well, hopefully this is Panners, and you try and give some reassurance, but then also give them some reality check that maybe it's gonna be something bad, I don't really know, and then I just follow them.
Tend to be like one is more like acute, or not acute necessarily, but more like traumatic, like an OCD. maybe.
No.
They're both similar. in
Yeah,
history.
OCDs are rarely traumatic.
Yeah.
So you just don't see them present, they present insidious. Like
And
it
then
just
this
hurts my
is-
motion. Yeah, my motion, especially, I almost always find it's the loss of motion that drives people in for OCD. It's really, I don't think I've ever seen an elbow OCD present that didn't have loss of motion. For some reason, that extension gets really limited. So now you've had all these injuries, what the heck do you do with them? Just give them a green light, tell them to go pitch 85 games a year, probably not. So obviously rehab's important. We don't let people get back to the throwing phase until they're pain-free, right? That's the goal. Full motion, full strength, pain-free ADLs, get them good and strengthened, work on their mechanics, and then start them throwing. So it's no different than like a couch to 5K program. You're coming off a stress fracture in your femur. You probably shouldn't go out and run a 5K this weekend. You need to work up to 5K distance over 2 months. That's what an interval throwing program is. So there's lots of different interval throwing programs out there, but essentially the concept's the same. Start at level, throw minimum like every 24 hours, start increasing how far you're throwing, how hard you're throwing, and then you just work your way up. And there's lots of different ones you can follow, but it is important to know they exist. It's essentially your functional return to play. And anybody who has elbow pain or shoulder pain who is bad enough to rehab, I put on these. There's different ones for like return to throwing, return to pitching. There's some intensified pitching ones. And then knowing when to advance is important. So I usually say you can't advance more than one step per day. If you're sore, but it resolves pretty quickly, you can try and repeat the previous workout. If it still hurts, you need a little bit more break time. If you're not having any significant soreness, you can advance. If you're recurrently sore all the time, you probably are starting things up too quickly. But the interval throwing programs are a bear to read. They're bear to interpret. So this is one that we hand out sometimes. So there's kind of a short toss phase and a long toss phase. You can't really progress more through a phase more than one per day, and you just kind of work them up. I usually send people to physical therapy and I make them start the interval throwing program there and then have them start walking through it. But I'll usually, I'll pull a couple up and try and find the one that looks like it's going to be the easiest to interpret, and then have people kind of work through them. But again, it's just slow progression back to throwing more than anything. Finished in an hour.
You ever have kids that are like, kind of, I mean, that's with that, I feel like the kids get kind of live, they like really want to get back, it's like, oh.
Yeah, it's like return to running. People just thanks, bye. Yeah. So the kids with little league shoulder, I'm pretty strict about. I'm like, you gotta progress over like 6 to 8 weeks. You just gotta follow this. You gotta go slow. And then anybody who has that down period in November, December, if they've lost the season because of injury, like using that time to progress them back with their throwing so that when they start in January, they're in a good place is helpful. No different than the cross-country kids. Lost the season to a stress fracture, they want to do indoor track, they're finally better. Okay, well, now you gotta actually run again, right? Like, I'm not gonna just send you back to track in the spring because we're gonna be in the same boat we're in now. So you try and really kind of progress it back slowly.
Or like the OCD versus the Panners, how long are you waiting? I know you said that sometimes
Yeah,
you
I
give
do
it time to see if
repeat imaging around 3 months.
Okay.
I start to just follow them.
if it's still there, is it at that point you're.
Another 3 months, like you just gotta watch and wait.
Yeah.
Yeah, but it can take 6 months or more to kind of figure out which way it's going. It's annoying.
Is it that 6 months when you're getting an MRI and talking about surgery, if they're still having a loss of range of motion?
Most of the Panners kids don't have loss of range of motion so much, it's just pain. If they, like, I'm for sure rehabbing them in the interim to get their range of motion back. So it's more what it looks like on X-ray. So just follow them with periodic X-rays and see how things look, and then 6 months probably repeat an MRI. But you've got to hold them out of throwing that whole time or
Right.
gymnastics or whatever you're dealing with.
Sport don't care, just like shut them down the whole, that.
Shut down their upper extremity stuff.
You ever had anyone or a parent say like, let's get the MRI now so we can get this figured out?
Oh, well, I MRI them off the bat,
Yeah,
but then I don't MRI them again for a while.
gotcha.
Yeah, I MRI them off the bat always when I see something like Tanner's or OCD.
Okay.
So just to get an idea of what it looks like then.
If you're like convinced it's an OCD, you're just like sending it right away.
Yeah, I send them to
People,
Ann. Yeah, they normally for an elbow one, you know, they tend to be a little bit older. I'll usually send them to adult ortho hand. So. And then they swear at me usually. They hate them. Because they don't, you know, like Anderson's fixed a couple of them, but they hate doing them because they're unfun to recover from and it's really hard to get the kid back, like the high level gymnast. It's good luck.
Yeah.
So it's hard. Not much fun.
And these return to play for like protocols for throwing or even like running. Do you have specific protocols that you follow? Do you keep that in therapy or do you just start at home?